Welcome to The Explainer, future nurses. Today, we're taking all that dense textbook knowledge and turning it into real-world clinical judgment. We're going to walk step by step through the exact pathway you'll use when assessing and caring for a term newborn. It's a huge physiological adjustment for these tiny humans in their first hours of life, so we're breaking it all down visually. By the time we wrap up this explainer, you won't just be memorizing facts. You're going to know exactly what to look for and, more importantly, how to step in and help. All right, let's take a super quick look at our agenda for today. We're kicking things off with transition and vital signs, then moving right into neurological signs and reflexes. After that, we've got the head-to-toe physical assessment, routine care and procedures, and the newborn stool cycle. And stick around because we're wrapping the whole thing up with a 5-question NCLEX knowledge check to make sure it all sticks. Okay, Section 1, Transition and Vital Signs, Establishing the Baseline. Those first 24 hours of life are absolutely wild as the newborn adjusts to the outside world, and your number one job at the bedside is getting that physiological baseline dialed in. So, you really need to know these specific numbers like the back of your hand, because any little deviation can be a major red flag for distress in your tiny patient. Look at the heart rate. We're talking 110 to 160 beats per minute. That's way faster than an adult, and it can be pretty irregular, so you've got to listen to that apical pulse for a full, uninterrupted minute. Next up, the respiratory rate usually sits right between 30 and 60 breaths per minute. Now, noisy breathing? Kind of normal, but if you see nasal flaring or chest retractions, that's a huge sign of respiratory distress. Finally, you want that axillary temperature sitting nice and cozy between 36.6 and 37.2 degrees Celsius. Newborns literally can't shiver to warm themselves up, so keeping them swaddled and doing skin-to-skin contact is a massive priority for us. Now, while you're checking those vitals, you might spot something called acrocyanosis. It's just a fancy word for blue hands and feet. This is completely normal in those first few hours because their peripheral circulation is just, well, a bit sluggish. Parents always freak out about this and think their baby is freezing, but here's the deal. You cannot use a baby's extremities to gauge their core body warmth. As long as their chest and belly are pink, they're doing great. But if you ever see central pallor or blueness on the core, that is not normal and you need to report it right away.
Moving on to Section 2, Neurological Signs and Reflexes, the nervous system in action. This is where we get to do some real detective work to see how that tiny central nervous system is developing.
This perfectly highlights the difference between two reflexes you are definitely going to be tested on. First, the Moro reflex. This is basically the startle reflex. If there's a loud noise or a sudden movement, the baby should symmetrically throw their arms out and bring them back in like they're going in for a hug, with their fingers making a little C shape. If they don't do this, or if only one arm moves, you might be looking at a fractured collarbone or a neurological issue. Then we have the tonic neck reflex. You'll see this when the baby is fast asleep. If their head is turned to the right, that right arm and leg stretch out straight and the left side pulls in. They literally look like a tiny little fencer ready for a duel.
All right, Section 3. Head-to-toe physical assessment, spotting the variations. This is where we dive into the physical exam, and knowing the difference between a harmless quirk and a serious medical issue is absolutely crucial for your boards. Okay, pay close attention to this one, because nursing exams love to trap you here. When a baby's head squeezes through the birth canal, it molds. Sometimes this causes caput cystodium. That's just soft tissue swelling, basically edema on the scalp. And because it's just in the soft tissue, it crosses right over the suture lines of the skull. It looks a little scary, but it goes away completely on its own. Now, contrast that with a cephalhematoma. This is an actual collection of blood trapped underneath the periosteum of one specific cranial bone. Because it's trapped under that tough membrane, it absolutely does not cross the suture line. It strictly respects the boundary of the bone. While you're up there, you also need to gently feel the fontanelles. These are the soft spots on the skull that let the head mold during birth and give the brain room to grow. The anterior fontanelle is diamond-shaped and takes a while to close, usually between 12 to 18 months. The posterior one on the back is a smaller triangle and closes way faster, usually by the end of month 2. When you gently run your fingers over them, they should feel totally flat. If you feel a bulging soft spot, you need to worry about increased intracranial pressure. If it feels sunken in, that's a massive, glaring sign of dehydration. Here we go with Section 4, Routine Care and Procedures, Intervening with Confidence. This is where your assessment turns into action, and where you'll be doing a ton of hands-on parent education. Let's talk airway clearance, because this is a skill you'll use constantly. Just remember the golden rule, M before N. Always suction the mouth before the nose. First things first, you've got to compress the bulb of the syringe before you even get near the baby. Then slip the tip into the side of the mouth. Stay away from the center so you don't make them gag.
Why mouth first? Well, if you go straight for the nose, the sudden feeling usually makes the baby gasp, and if they have mucus in their mouth, they're going to suck it right down into their lungs. So, compress, side of the mouth, empty, compress again, and then do the nostrils. Now, for families who choose circumcision, your education game needs to be top-notch. The biggest takeaway? Tell them about the yellow crust that forms during healing. It is supposed to be there. Do not let them scrub it off. Tell parents to keep the area clean with just warm water. Absolutely no alcohol wipes, because that will burn like crazy and mess up the healing. Make sure they're putting the diaper on loosely so it doesn't rub, and tell them exactly when to call the doctor if they see excessive redness, active bleeding, or, and this is a big one, if the baby hasn't peed, which could mean swelling is actually blocking the urethra.
Section 5. The newborn stool cycle. What to expect. Tracking intake and output is a huge part of your shift, and newborn poop goes through a very predictable, highly testable color change.
It's honestly fascinating how the body clears out the digestive tract. The very first stool is called meconium. It's a mix of amniotic fluid and secretions from their time in the womb, and it looks intense, thick, sticky, tarry, and black as night. But seeing it in that first 8 to 24 hours is a fantastic sign that the baby's bowels are working perfectly. Over the next week, as they start drinking milk, it shifts into a loose, greenish-yellow transitional stool. And finally, if they're breastfed, it settles into this bright yellow, soft, pasty consistency. Knowing this timeline is going to help you talk a lot of very anxious parents off the ledge. Okay, let's see what you've got. It's time for our Active Recall NCLEX knowledge check. Question 1. Vital signs. You're checking on a term newborn 4 hours after birth. Which vital sign ranges are you going to document as totally normal? Take a second and lock in your answer. And the correct answer is B. You want a heart rate of 110 to 160 and a respiratory rate of 30 to 60. Remember, a newborn's metabolic rate is in overdrive as they adjust to life on the outside. So these baselines are way higher than in adults. If you see lower numbers, you're looking at ranges for an older infant or a toddler, and anything higher is pushing into dangerous tachycardia. All right, let's try question 2. You're assessing a newborn's head, and you feel a swelling that definitely does not cross the suture lines of the skull. Think back to our visual comparison. What condition are we looking at here? You nailed it if you said C, cephalohematoma. Remember, this swelling respects the boundaries of the cranial sutures, unlike caput succedaneum. Caput is just squishy scalp edema that spreads everywhere, but a cephalohematoma is localized bleeding trapped right under the periosteum of a single bone, so it hits that suture line and stops. Getting this distinction right in your charting is an absolute must. Let's keep the momentum going with question 3 on routine care. You've got a baby with a mucousy airway and your trusty bulb syringe in hand. What is your very first anatomical target? Lock it in. The answer is B, the mouth, and before N every single time. You have to clear the mouth first so that if suctioning the nose makes them gasp, they don't inhale a bunch of gunk. And don't forget the classic exam trap. You have to squeeze that bulb before you put it in the baby's mouth. If you squeeze it after it's in, you're just blasting air and mucus straight down their throat. Moving on to question 4. A brand new mom is absolutely panicked because her one-day-old baby just had a thick, black, sticky blowout in their diaper. What is your best response as the nurse? The answer is D, education to the rescue. You can look that mom right in the eye and confidently tell her that this dark, tarry mess is completely normal meconium. It's exactly what we want to see on day 1 because it means the GI tract is open for business. No need to call the doctor, skip the stool test, and definitely don't stop feeding the baby. Just explain what it is, and you'll instantly turn a scary moment into a reassuring milestone.
All right, final question. Let's see if you can spot an emergency. Looking at these 4 common skin findings, 3 are just harmless variations, but 1 is a massive red flag. Which one of these means you need to intervene right now?
And the correct answer is B, early onset jaundice. Look, physiological jaundice that shows up after day 2 is a normal part of the body breaking down extra red blood cells. But if you see a baby turning yellow in their very first 24 hours of life, that is pathological. It points to a major issue like a blood incompatibility, and it is a full-blown emergency. Those blue hands, white pimples on the nose, and the gray spots on the sacrum, totally harmless. So as you gear up for your next clinical rotation, I want you to ask yourself, if catching just one tiny abnormal detail is the only thing standing between a healthy newborn and a dangerous emergency, is your baseline knowledge sharp enough to spot it? Thank you so much for hanging out with me on this explainer, and keep studying smart.